I would like to hand over back because we have to finish one talk of the previous session, and that should be completed. I think Dr. Salman Sharif is still there, and I would request Dr. Binod to please continue with the previous session before we move on to the next session. Is Dr. Binod there?
Yeah, yes, Varnan, I am here. Yes.
Yeah, please do.
Yeah, so we will we had one talk left in the guest lecture. So the last talk is spinal surgery today and in the future. And our speaker is Dr. Salman Sharif. He's from Pakistan. So Dr. Sharif, please, you start your talk. Dr. Sharif, whether he is there?
Dear friends, good morning. It's my pleasure to be part of NSSA Spine 2021. I'm honored and I'm grateful to Professor Ramani and our friends from India who invited me for a brilliant conference. Today I'll be talking about robotic surgery, which is about the future of spine surgery. I would welcome you to Pakistan whenever it's convenient. Why do we navigate in spine? Well, there's inaccurate spine hardware placement, nerve root injury, irritation reported in 3%, violation of more than 6 millimeter presenting with neurological deficits between D10 and L4 exists a safe zone which tolerates medial violation up to 4 millimeters, and a breach of medial and lateral pedicle cortex have been shown to reduce pull-out strength by 8% and 21% respectively. And this is a classification of the same that we can see. So what is an ideal image guidance system which gives surgeons confidence, surgeons accuracy and precision, and significantly decrease implant placement time and amount of healthy tissue being removed? It leads to greater system uptake and utilization. There was a study of accuracy of freehand pedicle screw placement in thoracic and lumbar spine published in Neurosurgery, which showed that the accuracy is pretty good despite using the freehand, but the malposition rates are up to 2 to 31% in larger series. Again, another study which showed a malposition rate was utilizing a 2D fluoroscopy based techniques up to 2 to 22%. Randomized controlled trial of 100 well-matched subjects randomized to either pedicle screw placement with or without image guidance and demonstrated a significantly lower pedicle perforation rate in image guidance group. So we can see that if we use image guidance, obviously compared to with or without a freehand or using a 2D image intensifier, the accuracy may not be as good. A randomized controlled trial showed that using an image-guided technique or 2D fluoroscopy, significant decrease in cortical breach, 2% was 23% in image-guided group. Fluoroscopy-based 2D navigation is the most commonly used form of navigation. A meta-analysis demonstrated overall breach rates of 31% and 15% using 2D fluoroscopy and virtual fluoroscopy respectively. There's no three-dimensional special feedback. Radiation exposure is a big problem itself. So 3D image intensifiers work very well, but again, have their risk if you use it during surgery. Then OARM, obviously OARM has its own benefit, and you can use in theater immediately after surgery for seeing the accuracy of the screws. And then navigation registration nowadays can also be done with the help of either a point pair system or a manual registration or registration using a stick-on points that can be picked up by the navigation system. What about the intraoperative CT? The intraoperative CT eliminates the positional variance that degrade the accuracy of preoperative CT system. Wood showed that 6.4% pedicle breach rate using preoperative CT 3D stereotactic compared with a breach rate of 1% using intraoperative CT stereotactic radiation navigation. A recent study of 2,132 lumbosacral pedicle screw placed percutaneously under intraoperative CT-based 3D navigation showed a breach rate of 0.3%, which is fantastic. Radiation reduction, why and how it does it? Well, when we use a total fluoroscopy, time is minimized to 2 minutes per case. The annual threshold for radiation exposure measured in MREM was surpassed just after doing 300 cases. Unprotected MI surgeons performing a TLIF will go up to their limit after just 194 cases with average of 1.38 levels per case. What are the limitations and opportunities for surgical navigation? Well, an accumulation of multiple unchecked flow disruptions during a surgical workflow have been shown to empirically lead to a higher prevalence of surgical errors and potentially alter the outcome of an operation. What are the problems of current navigation system? In the interest of time, I'm going to keep this limited. It does not allow to visualize anatomical structures without soft tissue exposure by just looking down at the operative field. Requires surgeons to develop a complex and anatomical hand-eye coordination, requiring a long learning process. Stopping surgery to see the screen, causing a disruptive surgical flow. It relies on 2D images to describe a 3D anatomical structure and are not intuitive for surgeons, creating limited functionality and prolonged surgical time. Your plan could be just going from one point A to point B, but the reality would be something else, and that's what you need to be aware about. So there was a global survey of showed that only 11% of surgeons in North America and Europe are using navigation a year ago. They cited disadvantages, including high acquisition cost, lack of adequate training, equipment problems, and disruption of OR workflow. Obviously, there were registration problems. Time between the preoperative scans to the time of the procedure leads to navigation errors due to reference frame shifting, fiducial markers moving, skin movement, and all this has been shown in a recent study by Roger Hartle. Well, this famous thing about O-arm failure trapped surgeon prone on Jackson table was published in 2015. And robotic versus fluoroscopy guided pedicle screw insertion metastatic spine, a match cohort study showed that really accuracy was completely different in these two groups. So if you look at the robotic technique and conventional technique, and if you look at the misplacements in the upper thoracic spine, robotic is 4.7 versus 8.4. Lower thoracic 7 to 7, lumbosacral 3.6 to 0.9, and total was 15 versus 16. And you can see robot does not know if the medial could be a problematic area, so robot goes overall all over the place. Whereas when using conventional, obviously when we are going around, we don't want to be breaching the medial cortex, so we stay slightly onto the lateral side. So accuracy, radiation time, and post-operative infections are comparable to the conventional technique according to this study. What about the learning curve for 3D navigation thoracolumbar pedicle screw placement? So if you look at this mean navigation time in the first part of these patients, it was up to 15 minutes and then dropped down to 8 minutes. Mean control 3D scan time was 11, dropped down to 6. And mean pedicle screw insertion time dropped down from 5 to 3 minutes. So mean correctly positioned pedicle screws increased from 83% to 95% by the study from Bernard Meyer. 3D fluoro navigation surgery necessitates intraoperative 3D scan acquisition, obviously. It correctly draping of the surgical site without unintentional movement of the reference array, handling and correct positioning of tracking device and C-arm, and the size of rendered 3D cube of 12 centimeter may necessitate additional 3D scans for multi-level instrumentation of more than 3 to 4 lumbar or 4 to 5 thoracic levels. Intraoperative maneuvers, as we know, leads to unintentional displacement of the reference array and can lead to inaccurate pedicle screw placements. Accuracy and revision rate of intraoperative CT point-to-point navigation for far lateral pedicle screws placement, 11-year study, 1,054 patients. And what they showed was that 8 patients required a revision for screw displacement, which was 0.8%, with the use of reference markers in intraoperative CT-based spinal point-to-point navigation. They achieved a high accuracy of screw placement from a low revision rate to 0.8%. So total screw misplacement rate was dropped down to 0.3, which was only 16 out of 6,059 screws. Robotic systems are also reliant upon the radiographic image in stereotaxy for user-operated trajectory planning, which is then performed by a fully automated robot that locks the desired screw trajectory for the surgeon. The first robotic application was demonstrated in 85 when a brain biopsy was done. Since then, it's come a long way. Da Vinci's robot has been used for some time, but because of its being cumbersome, there are problems associated with the newer robotic systems are easier to handle, are not that cumbersome, and are easy to use, and have got different advantages over the old systems. So we have the three broad categories for robots. One is supervisory control system, where the machine is programmed with predetermined action that are carried out with robotic autonomy and close surgeon supervision. The other is telesurgical system like Da Vinci. So, you know, you are the surgeon is controlling everything and you're sitting on the side on a workstation and controlling it. Then there's shared control models, where there's a form of a co-autonomy, allowing both the surgeon robot to simultaneously control the motions. So if you look at this screw placement with intraoperative CT, aero group versus an O-arm group, and see what's the difference between the two. And generally, if we see that intraoperative CT performed better than the O-arm group, and the results were better in that group as well. Intraoperative CT navigation has its own limitation with inaccuracy detected from the tracking system due to blood stains on the reflective markers. The instrument attachment and navigation markers may loosen during surgery, require recalibration. Use of hammer and mallet may allow the whole scene to change and move, and that's when everything needs to be readjusted. Soft tissue movements and instrumentation at the large distance from the tracking device will change all this. Increase the distance from the array may contribute to reduce accuracy as well. Pedicle screw placement using augmented reality, surgical navigation with an intraoperative 3D imaging. The first in-human prospective cohort study had 253 lumbosacral and thoracic pedicle screws on 20 consecutive patients, and they showed an overall accuracy of 90%. So augmented reality surgical navigation can be clinically used to place thoracic and lumbosacral screws with a high accuracy with acceptable navigation time. And we have shown that before, that all this has improved over time. So there are different kinds of robots that are available that we can see. Da Vinci's is shown here, Stryker's is shown here. Rosa robotic arm, which obviously has a machine right next to the patient, and then the robotic arm moves in and does the work. Whereas with spine assist robot, it is fixed onto the patient itself, mounted on a spinous process. And you can see that the difference between the two. One is adjusted on the bone, second on the floor, and preoperative CT is required in one, the other none. If you can see a first case that was used for scoliosis correction using the robot, and how it works, I'm not going to go into detail of that, but basically the whole system, the scans are inserted, and then we use the system to plan. And once we have planned, then we use we put in a pin, and we then use a light to see where exactly the skin surface is. And then we use the same to insert. We just ask the robot to do its work, and it automatically does it without us interfering. Financial advantages of the robotic system have clearly shown that conservative saving estimates of about $600,000 during a year at an academic center performing 557 elective thoracolumbar instrumentation cases. So application of robotic spine surgery is cost-effective, resulting in lesser revision surgery, lower infection rates, reducing the length of stay, and shorter operative time. In conclusions, robotic surgery may be the future of spine surgery, and robotic assistance system represent an emerging modality that may also facilitate high accuracy of hardware placement. I'm again grateful to the organizing committee for inviting, and hopefully we'll see each other soon. Thank you.
I think Dr. Salman is not available here. It's his recorded talk. So we are concluding this session and handing over to the organizers for the next session.